طيب، بسم الله الرحمن الرحيم. النهارده مش عارفه هنطول عليكم ولا مش هنطول عليكم، بس الميكروفون حالا عامله في نفسي مش طبيعيه. تمام. حاضر. طيب النهارده طبعا ان شاء الله مهم، بس يعني I hope ان احنا نبقى in time. هنكمل بقى من حيث آه، وقفنا. اوكي. طيب احنا كنا بنتكلم على هايبرتنشن، وصح مش احنا وقفنا في الهايبرتنشن؟ وهيجي لنا بقى كده جروبس اوف دراجز اللي هم الفازو دايليترز. دول هيبقى اول مره نسمع عنهم. هم الحقيقه يعني الفارماكولوجي بتاعت الانتي هايبرتنسيف دراجز مهمه. الالجوريزمز زي ما احنا قلنا والدراج تشويسز هتبقى اكتر في العملي. انا بعت دلوقتي لاستاذه الدكتوره حنان مبارك. I sent her the ILOs. There is a very big list of ILOs. I have highlighted in yellow the ones that you should revise for the purpose of the end of module exam, because I don't like to cancel anything. We cannot cancel anything. But the good way is to try to divide this. So you are going to concentrate on these ILOs. You will find some not highlighted at all and some highlighted in blue. You concentrate only on what's highlighted in yellow. On what's highlighted in yellow. Now, with each of the coming two exams, practical exam and the end of year exam, I'm going to resend the list of ILOs with different ILOs to concentrate on. So I make sure that by the end of the year, you have read everything. Okay? Some of them are going to be repeated according to their importance. Okay? Making sure also that the exam covers everything. So, recapping on the antihypertensives, احنا اتكلمنا عن السيمباثيك ديبريسنس في adrenergic receptor blockers، من ضمنهم الالفا بلوكرز والبيتا بلوكرز. دي غير طبعا السنترال sympathetic depressants. الالفا بلوكرز we know already about prazosin. It's important to start with a small dose and then increase it gradually. And why is that? Because of the first dose hypotension. And again, this is a drug that's good also for heart failure, because it will decrease the preload and the afterload, and again good for prostatic hyperplasia. So whenever you have a patient with the two conditions, this is a favorable drug for that patient, because a patient is going to benefit from the alpha block in the two conditions. Okay. Is it already recording? Yeah, sure. Okay. So shifting to the adverse events or adverse effects of prazosin, you already know about them. You have first dose hypotension, headache because of the vasodilatation, okay? Dizziness, because of, if there's some hypotension, there will be dizziness. Fluid retention, which is a form of, well, if there's hypotension, then there can be salt and water retention as well, or vasodilatation. And failure of ejaculation in males, because ejaculation is driven by the alpha receptors. Beta blockers, this is again about why beta blockers are beneficial in hypertension, and I think this has been mentioned before. يعني ده إعادة للكلام، تمام؟ This is a repetition. So I think this is repeated, but it is important. The drugs that combine alpha and beta blocking action, again, they are important. Labetalol, it has both non-selective beta and alpha-1 block, and this is the ratio. This does not affect the cardiac output, and it has no intrinsic sympathomatic activity. So it does not affect the cardiac output because by the beta blocking action, it will tend to decrease the cardiac output. And by the alpha blocking action and the vasodilatation, it will tend to increase the cardiac output. So the net is no change in the cardiac output. Okay, it might produce a rapid drop in the blood pressure, but it will not, and it will have an anti-renin action, but no tachycardia because of the beta block. Okay. It will be used in hypertension, and it's good for pheochromocytoma because it's going to block both the alpha and the beta receptors. It's a drug that can be given orally and intravenously, so it's good for emergencies and in hypertension with pregnancy as well. Carvedilol is another alpha and beta blocker. From its name, CAR, it is a good drug for the heart, and it is used in cases of heart failure. Calcium channel blockers in hypertension, you will find that this is again repeated, but they are a form of vasodilators. Now we are going to concentrate on the direct vasodilators. Direct vasodilators are usually late in the list of drugs that are used in treatment of hypertension. You use them when other drugs like ACE inhibitors and diuretics and all these combinations, when they fail, you usually add a direct dilator, something like hydralazine. Hydralazine has many special or specific features in its pharmacology. First of all, it is mainly arteriolar dilator. So it dilates mainly the arterial side, which means what? So it will produce reflex sympathetic stimulation, salt and water retention on the long run, and immediately it's going to cause reflex tachycardia. So it's a drug that causes intense reflex tachycardia. This is, as I told you, tachycardia. Always view it as something good or bad? Very bad. So always view tachycardia as something very bad, especially in a hypertensive patient who might be liable for angina. Tachycardia with hydralazine may result in even anginal attacks. So you can get an anginal attack precipitated by tachycardia. Tachycardia is always a very bad side effect in patients, especially treated for hypertension and patients thrown to angina. That's why you should not use it in angina unless you add a beta blocker, and you might get also edema from the stimulation of renin-angiotensin system. Any vasodilatation will produce headache flushing. So this is just a side effect that you can very easily know just by knowing that the drug is a vasodilator, especially on the arterial side. Headache and flushing. Now, hydralazine is known for its metabolism by acetylation. This is an area of pharmacogenetics. What's pharmacogenetics? It's kinetics or dynamics affected by the genetic makeup of that individual. So we have slow acetylators and rapid acetylators. So the slow acetylators are going to get more side effects of hydralazine. So this is, we can call it a form of idiosyncrasy, or a form of a change in the properties as based on the genetic differences between people. Peculiar to hydralazine is that it might produce picture which is similar to systemic lupus erythematosus. Now, what's systemic lupus erythematosus? It is an autoimmune disease, and it is characterized by flushing in the malar area, in the cheeks, and it's not a good autoimmune disease because ultimately it is going to damage what? Do you know? It's going to damage the kidneys. Okay, so it's very important to know that this is a situation where you might confuse the picture of the patient with a patient with systemic lupus erythematosus, but this is reversible by stopping the drug. So it might, excite an allergic reaction that makes the patient resemble rheumatoid arthritis patient or lupus, but as you can see, this is a reversible side effect. It's used, of course, in hypertension, and it might be used in heart failure, but of course, it will be added to other measures because of the tachycardia, to control the tachycardia. Now we have three other vasodilators. We have minoxidil, we have diazoxide, and we have sodium nitroprusside. They are interesting because each of them has something characteristic to it. Minoxidil is a very powerful arteriodilator, and it is used orally. For some reason, its vasodilatation is very effective regarding hair follicles, up to the point that it results in something called hypertrichosis. Okay? What's the difference between hypertrichosis and hirsutism? You heard the word hirsutism? Hirsutism is increase in hair growth with the male distribution. Hypertrichosis is increase in hair growth وخلاص, not necessarily following the male distribution of hair growth, because this is related to vasodilatation. This is a side effect of minoxidil. However, minoxidil is one of the very few drugs that are effective topically to help in the treatment of alopecia. So that's what's characteristic about minoxidil. So it's a potassium channel activator leading to hyperpolarization, leading to vasodilatation. You can call it a direct vasodilator. Disadvantage, it will result, of course, again, blah, 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 with the vasodilatation. I don't need to repeat this. Hypertrichosis stimulates hair growth, so it is used in severe hypertension, added to a beta blocker and a loop diuretic to antagonize the edema and the tachycardia, and in resistant heart failure, and topically in alopecia as lotions and creams, and it is used, and you can find it in everywhere. Okay, it is effective. So next is the diazoxide. Again, this is a vasodilator. Again, it activates potassium channels, results in hyperpolarization, same decrease in blood pressure mechanism, tachycardia, renin-angiotensin system stimulation. Okay, however, it results in hyperglycemia, and I need to highlight this, please. I will highlight it. Why? Because the use depends on it. First of all, it's used in emergency hypertension because it's a powerful vasodilator, and it can be used in cases of hypoglycemia due to hyperinsulinoma. So this is, again, something characteristic and peculiar about diazoxide. Another vasodilator is the sodium nitroprusside. Sodium nitroprusside is a mixed or a balanced dilator. It dilates arterioles and venules, venular and arteriolar side, and it also inhibits platelet aggregation. This is, of course, you can work it out, all of it. Vasodilatation decreases total peripheral resistance, venous decreases end diastolic volume and decreases venous return, and cardiac output is going to be maintained because we're going to decrease both the total peripheral resistance and the end diastolic volume. It is given by IV infusion. Why is that? Because it has a very short T-half. But the thing is, prolonged infusion for more than, let's say, 3 days, it may result in some cyanide intoxication. And okay, so it is very powerful. It can result in hypotension. It cannot be stopped suddenly. Please add it to the list of drugs that cannot be stopped suddenly. And it might lead to cyanide intoxication with acidosis and arrhythmia. You can treat that by thiosulfate. What's prolonged? If you're going to infuse it, let's say, for some days, more than 2-3 days, then you start to see this. It is also teratogenic. Of course, a drug like this will be used in emergency hypertension, hypertensive encephalopathy, in emergency heart failure, to control hypotension. When did I tell you you need a controlled hypotension? Controlled hypotension. We shift the blood pressure to very low level, to make the operation field very clean. In plastic surgery, in neurosurgery, sometimes you bring the patient to the very hypotensive side. Okay, you decrease the blood pressure really markedly so that you have a clean operation field. And in cases with aortic dissection, also can be used until we operate on the patient. There are precautions with nitroprusside, it is given by intravenous infusion. It has to be protected from light. It needs to be a fresh solution. There should be continuous monitoring, and you never stop it suddenly. Okay, we're done with the hypertension. Any question about hypertension? I've been asked, one sent me a question on WhatsApp, whether you need just to stick to what's highlighted in yellow. Okay, stick to what's highlighted in yellow. Names, stick to what's highlighted in yellow. I don't expect you to memorize the names that are not highlighted in yellow at this stage. خلاص? Inshallah. So that's the question. That's the answer for the question. طيب, we cannot go into all the details, of course. The heart failure. There are some foundation points about heart failure. That, yes. مش مرضي في العمل. خليها العمل. عشان احنا الوقت we need to save it for what's coming in this exam. Trust me for it. Okay? I will guide you through the next 2 coming exams. Don't worry. Okay? طيب. طيب. Heart failure can be classified in many ways. Acute heart failure or chronic heart failure. And again, chronic heart failure, we focus on the ejection fraction. What's the ejection fraction? It is the percentage of the end diastolic volume that is actually ejected outside the heart. Okay, so it is the stroke volume divided by the end diastolic volume times 100. This is the ejection fraction. It gives you what? An idea about what? About how severe is the heart failure. So this is a very important point of following up the patient and knowing how severe the heart failure is. Sorry for this. Again, you classify the heart failure, you classify it into right-sided and left-sided heart failure. Now, anything wrong with the lungs is going to get us right-sided heart failure. Anything wrong with the mitral valve or with the ventricle, the left ventricle, is going to get us left-sided heart failure. And in both cases, you see symptoms of low cardiac output. ده كده تمام بالنسبة لكل الهارت failure. Backward symptoms, in case of left-sided heart failure, there is pulmonary edema, which can lead to acute pulmonary edema if there is decompensation. Right-sided heart failure will result in systemic congestion and edema. Why is this important? Because these are the symptoms that improve when you give treatment. The problem with a patient with heart failure, ليه ممكن يجي له heart failure؟ مثلا عنده severe hypertension for so long, عنده myocardial infarction, عنده whatever reason there is low cardiac output, there will be compensatory mechanisms. Compensatory mechanisms consist of what? 3 things. Salt and water retention by activation of renin-angiotensin system, which puts more load on the heart. Tachycardia to increase the cardiac output, which puts more load on the heart. And cardiac remodeling, which on the long run weakens the heart. So when I used to study heart failure in the back days, we used to think of inotropics as the main treatment. Now the main treatment is targeting the compensatory mechanisms. You try to treat the cause and you try to control those injurious compensatory mechanisms. And how do you judge the success of treatment? By survival of the patient. Because patient with heart failure, he's a dying patient. There is survival within years. Okay? So you see the effect by prolonging survival of this patient as you see it in clinical trials. So all this, of course, this is the background. All this is a background, the pathology of heart failure. This is about the symptoms. Everything about acute decompensated heart failure is going to be for your practical exam. Everything, everything. Now, let's concentrate on chronic heart failure with reduced ejection fraction. Now, let's see the headlines. What options do we have? Okay, we have angiotensin converting enzyme inhibitors. We have angiotensin receptor blockers. We have aldosterone antagonists. We have beta blockers. What do these four have in common? These four, what do they have in common? They are all antagonists of the renin-angiotensin system. Then, what do you have, Tani? You have diuretics. You have Neprilysin inhibitors. Okay, which actually should be up there. Have you seen any inotropics so far? في ولا inotropic لحد دلوقتي؟ تخيل not a single inotropic. الinotropic جاي امتى بقى؟ After hyperpolarization inhibitor, sodium glucose, and then the cardiac glycosides as inotropics. Okay, so they are not, inotropics are not anymore on the front line of the treatment of chronic heart failure. خلاص, up to for digitalis, the main indication now for digitalis is control of ventricular rhythm in patients with atrial arrhythmia, flutter or fibrillation. This is the only area about digitalis that is coming in your end of module exam. Hello, كده? So in your end of module exam, I will not ask you about the mechanism of action of digitalis. I will not ask you about its side effects, about toxicity, about contraindication. I will not. It's not canceled. You will see it later in later exams. But I am very much interested that you know about the rationale of using digitalis in patients with atrial flutter and fibrillation. Okay, I will come back to this because I need to start from the start to just span what we have here for heart failure treatment. Renin-angiotensin system inhibitor, angiotensin converting enzyme inhibitor, they decrease the preload of the afterload. This is very important. All what's highlighted here is very important, that you use them in all stages of heart failure, the early and the late. So it's all stages. That the symptomatic and the asymptomatic patients. Why the asymptomatic patients? Because you want to control even the compensatory mechanisms and you have a good impact on survival. You don't want the patient to change to asymptomatic patient. And you start with low doses or titrate to the targeted or the maximum tolerated. So you give the patient as much as they can take or the dose that you need. Okay, angiotensin receptor blockers, of course, you know the difference. They are good in cases if the patient has accompanying bronchial asthma or angioedema because they do not increase bradykinin. Aldosterone receptor antagonists. Okay, it's dispironolactone and eplerenone. The direct antagonists of aldosterone receptor should be reserved for most cases of heart failure, for severe cases of heart failure or heart with recent myocardial infarction, because the aldosterone receptor antagonists are very good in limiting the remodeling of the myocardium. And they are not powerful dilators. So we reserve them for the resistant cases because you don't want to give the patient so many medications. So you start with ACE inhibitor, for example. You start with some lines of treatment. Now, if this is all not working, then you add what? Aldosterone receptor antagonists, okay, like spironolactone or eplerenone. Beta blockers, why do you use beta blockers in heart failure? Why? Main reason to control, okay, manifestations of sympathetic toxicity, which is mainly tachycardia. Tachycardia of heart failure is injurious. You want to control the tachycardia. In the old days, they used to tell us that beta blockers are contraindicated in heart failure. Then, when we were graduated, we found that beta blockers are given in heart failure. طيب contraindicated ولا used? Used, but to the point that the patient is tolerating. يعني you don't give the patient beta blocker and you decrease the cardiac output and the patient decompensates. So you just control the tachycardia and according to the patient condition. If you increase the beta blocker dose too much, the patient might decompensate. So this is again needs monitoring, and the dose depends on what the patient is tolerating. The patient مستحمل ايه. Yeah, sympathetic, they stimulate, the sympathetic stimulates البيتا والrenin-angiotensin system. They protect the heart from cardiotoxic effect by the sympathetic stimulation, and they decrease mortality and they decrease remodeling. So the benefit is proven in clinical trials. You don't need to memorize exactly the names used in heart failure, although, as I told you, beta blockers are not interchangeable. So metoprolol, bisoprolol, carvedilol, especially carvedilol, these were proven in clinical trials. So you don't just give any beta blocker, okay? Given to patients starting at a low dose and gradually increasing until reaching the targeted dose or well tolerated by the patient. What's not well tolerated? Cardiac output decreases so much, bradycardia, now the patient decompensates. So you have to you have to maintain the balance. You get the benefit without too many side effects. Now, of course, diuretics are going to decrease the blood volume, decrease the end diastolic volume. You can use hydrochlorothiazide or thiazide diuretics or loop diuretics. Again, these have venodilator action. Now we have neprilysin inhibitor, sacubitril. I wish I brought a diagram here, but let me ask you, what's neprilysin? We have in our body something called natriuretic peptides. How many natriuretic peptides do you know? تعرفوا أنهي؟ في atrial natriuretic peptide, brain natriuretic peptide. طيب النابريلايسين ده ايه بقى؟ It is degrading atrial natriuretic peptide. So we want to inhibit this neprilysin. طب why not? اتفضل. في الايه؟ في most severe cases. طيب انت when you're treating a patient with heart failure, how many drugs do you want to give the patient? يعني do you want to give one drug if possible, or you want to give many drugs? You want to start with one drug or two drugs. Are you going to start with something efficacious or are you going to start with something weak? Of course. تمام? So you reserve spironolactone for cases that are resistant to these forms of treatment, okay? And because it's not going to be a strong diuretic, however, you are going to get the benefit of limitation of remodeling. Okay? طيب تاني ليه ما نديش الاتريال ناتريوتيك بيبتايد؟ ما نديه اصل اللعبه دي this game is repeated in pharmacology. Why not to give atrial natriuretic peptide or brain natriuretic peptide? Do we give it? We do. We give an analog, neseritide. It's an analog of natriuretic peptide. So we give it, but we give it ازاي? How? IV. You give it IV. So that's why you see it in acute heart failure. And why is that? Why don't you give it orally? Because it's a peptide. It's going to be metabolized. So you cannot give neseritide orally. That's why you reserve it for acute cases. Type. What do we do if we cannot give something orally? Okay? Because you're going to see the same in diabetes next year. You want to give a glucagon-like peptide. You cannot give the glucagon-like peptide. You give something that inhibits the enzyme which degrades this mediator, the one you want to increase. So you give something that is going to inhibit neprilysin. In this way, you're going to increase the level of what? Yes, especially that this neprilysin also degrades what? Bradykinin. So you're going to get an excess of natriuretic peptides and bradykinin. This is very good. But imagine this enzyme also degrades what? Angiotensin. So now you need to block angiotensin. So how do you block angiotensin? Why don't you give ACE inhibitor? Because ACE inhibitor is going to increase the bradykinin even more. So this is a fixed combination. What does it mean, a fixed combination? You don't get sacubitril in the market alone. You don't get it alone. You get it always with an angiotensin receptor blocker. Because you are sure that atrial natriuretic peptides are going to increase, bradykinin is going to increase, however, angiotensin also is going to increase. So you need to block the receptors of angiotensin by an angiotensin receptor blocker, and you cannot give an ACE inhibitor because you're going to increase the bradykinin even more. So anything about this, anything not understandable, so it's a prodrug, okay, active form inhibits enzyme neprilysin, which is responsible for the degradation of brain natriuretic peptide, which lowers the blood pressure, induces vasodilatation, natriuretic effect, so many good effects of the natriuretic peptide. In addition, it degrades a variety of peptides, including bradykinin, inflammatory mediator, vasodilator action. Because neprilysin breaks down angiotensin 2, inhibiting neprilysin will result in increase in angiotensin 2, so we need an angiotensin receptor blocker. That's why it is there in a fixed combination with valsartan. So the company that invented sacubitril, I'm not sure whether it was the same company that invented valsartan, but they have taken valsartan anyway. They are selling valsartan anyway, whether or not they invented it. ماشي. مش حقنة، حباية, and it's a fixed combination. Remember this name, fixed combination. It is a term. Fixed combination, when you see the tablet, مثلا 50 milligrams / 5. So it's 50 of one drug, 5 of the other. Like, for example, you have fixed combination with hydrochlorothiazide with amyloride. Fixed combination. Because amyloride will correct the hypokalemia of hydrochlorothiazide, and it's going to help the diuretic action. So you have a fixed combination. By the way, fixed combinations are such a business. Now, I walked into the diabetes conference of the National Diabetes Association in Egypt 2 years ago. And I wanted to see the new drugs. كذا زائد كذا زائد كذا. This one with this. Amlodipine with معرفش ايه. Nifedipine with كذا كذا. They are all fixed combinations because now they are reusing these drugs with products that are new, but actually these are combination of 2 products. Sometimes this is justified, and sometimes this is for business a little bit. But what is the justification? They tell you we decrease the pill burden. It's not good that the patient is going to hold مثلا 5 tablets and take the 5 tablets all together. So they are always trying to fix the drugs together, especially with chronic treatments. طيب ما علينا. Therefore, sacubitril cannot be used with ACE inhibitors. It will increase the risk of angioedema. Again, next is hyperpolarization activated cyclic nucleotide gated channel blocker ivabradine. You look into it. Why is ivabradine important here? It is going to decrease the tachycardia, especially if the patient cannot what? I want the correct name. If the patient cannot tolerate beta blocker. Now you need to know the word tolerate. Tolerate is a word that you need to know. If the patient cannot tolerate beta blocker, then ivabradine is a solution. What is the difference between ivabradine and beta blocker in controlling atrial tachycardia? Yes, it has to be a sinus rhythm. Beta blockers will inhibit the SA node and will inhibit AV conduction, just like verapamil. It will inhibit AV conduction. However, ivabradine will only inhibit the SA node. So who is a patient who will not benefit from ivabradine? A patient with atrial flutter or a patient with atrial fibrillation, because these patients do not get the rhythm from the SA node. They get it from ectopic foci. So sodium glucose co-transporter inhibitors, I told you the whole story that they were invented for diabetes, and then there were studies showing that they are beneficial. Memorize the names. Memorize the names. Empagliflozin, canagliflozin, dapagliflozin, please memorize the names, have been shown to reduce the risk of heart failure hospitalization. Where did this come from? الجملة دي تيجي منين؟ clinical trial. جروب خد وجروب ما خدش. شوف لي مين هيدخل المستشفى أسرع. اللي ما خدش. التاني ما دخلش المستشفى، ما راحش الإي آر، ما راحش. They didn't go to the ER so often. Was not hospitalized. Okay? Reduce glucose absorption by inhibiting high capacity sodium glucose co-transporter leads to increase in concentration of chloride in the distal tubule, resetting of the tubuloglomerular feedback mechanism, which results in contraction of the plasma volume without activation of sympathetic nervous system. This is a killing sentence. This is a killing sentence. There is something called glomerulotubular feedback or tubuloglomerular feedback. You know about it? يزود الفلتريشن. انت ما فلترتش الصوديوم كفايه، زود لي الفلتريشن. اوكي؟ طيب ف there will be when there will be an increased chloride in the distal tubule, it will set this glomerulotubular feedback, which will result in I have found papers that explain this, بس I choose not to go into this detail now because there will be more important things to I promise to explain this later, okay? Because it will take so much of time, okay, from us. And again, in the practical, maybe we are going to stop at this because in the practical, the glucose co-transporter inhibitors, they are there in the treatment of heart failure. So maybe you are going to stop at this in the practical, okay? So again, I delay this. So the cardiac glycosides, okay, they are highlighted, but I tell you that you are going to be asked only about the uses of digitalis for the purpose of this exam, especially in atrial flutter and fibrillation. And why is it beneficial? Because it is going to worsen the atrium. Okay, no problem. Okay, we don't care about the atrium, we care about the ventricle. Okay, so it's going to inhibit AV conduction, and it's going to inhibit AV conduction because it has a vagal and extravagal action. So it's going to inhibit AV conduction. This is digitalis. So when we inhibit AV conduction, we don't deliver the atrial rate to the ventricle. And this is the most important thing. So the ventricles will be slower, will be more regular because they will be slower, and they will be more efficient because there will be time to fill and there will be good time to contract. So this is going to improve the ventricular contraction and eliminate pulse deficit. What is pulse deficit? Yes, if the ventricles are contracting irregularly, one beat is going to be strong and the other beat is going to be weak. The strong beat, you will be able to feel it apically and radially. The weak beat, you feel it only at the apex. So this is called pulse deficit. You count the rate on the apex, okay? You find it higher than the rate radially. This is called pulse deficit. If you're going to make the ventricles more regular and slower, most of the beats are going to be weak or strong. Strong, so this is going to eliminate the pulse deficit. And again, in atrial flutter, again, it will diminish AV conduction and protect the ventricle. This is all what you need to know about digitalis for the purpose of this exam. Okay, so to improve patient with heart failure, we improve the symptoms with diuretics, salt and water retention, with digoxin, again, It will work if the patient has atrial fibrillation as well. AC inhibitors, and survival is improved by AC inhibitors, beta blockers, and spironolactone. This is very important. These three drugs, they increase survival. Cardiac dysrhythmias, again, I will not explain cardiac dysrhythmias now because maybe they need to be written in a slightly different way than this. So for the purpose of this exam, I want you to know 2 or 3 things about cardiac arrhythmia, and that's it. First thing, you know about lidocaine. Okay? And lidocaine, it's blocking the sodium channels, and you will not even be asked for this exam whether it's activated, inactivated. We will not touch on this for the coming exam. However, it has extensive metabolism, so this is a drug given intravenously for emergency arrhythmias, especially ventricular arrhythmias, but it will not be given in ventricular arrhythmia with heart block. So it can be used, okay, in myocardial infarction, arrhythmia due to myocardial infarction, arrhythmia due to general anesthesia, arrhythmia during cardiac surgery, arrhythmia induced by digitalis. Lidocaine is going to be effective in all of these, in ventricular arrhythmias, in all these conditions, but it has to be what? Not accompanied with heart block, okay? Type. What about liver disease and patients with reduced hepatic blood flow, especially those patients with congestive heart failure and patients on beta blockers? They will have reduced blood flow into the liver. And it's metabolized in the liver, and it has extensive metabolism. Is it contraindicated? No, you just need to increase the dose, okay, and monitor the infusion. It might lead to CNS effects, might lead to CNS effects, even convulsions. Actually, you're going to see this next year with the local anesthesia. Frequently, you go to the dentist and you take local anesthesia for tooth extraction, for whatever thing you do at a dentist. Local anesthetics mostly are derivatives of lidocaine, okay? They should be very safe drugs as long as they have not entered the bloodstream. If they enter the bloodstream, they lead to cardiac arrhythmias and sometimes convulsions. They become very serious drugs. That's why with local injection of an anesthetic, you always need to aspirate before injection. Why is that? Because you need to be sure you are not injecting in a vessel. So they are, as local anesthetics, they are very safe drugs if they are not into the blood vessel. Why am I mentioning this? Because this is one of them. Lidocaine is actually used as a local anesthetic. It is a local anesthetic, and if you give it intravenous, it will be used in the treatment of serious cardiac ventricular arrhythmias in all these situations if there is no heart block, with the caution to decrease the dose in these conditions if there is hepatic impairment. Next thing I want you to know about amiodarone. Okay, it is of class 3 anti-arrhythmics. However, it has an action of all classes. It has class 1 action, it has class 2 action, and it has class 4 action. Amiodarone has a very long half-life, which means that it is stored. What does it mean if it has a very long half-life? It is stored somewhere in the body. Drugs with a very, very long half-life in days, 25 to 60 days, which means that these drugs, usually they have very large volume of distribution. They are hidden somewhere. So amiodarone becomes hidden in certain tissues, like hidden in tissues of the lungs and in the thyroid. So it is hidden in these tissues. That's why this is the panel of side effects. Amiodarone will be effective in ventricular and supraventricular arrhythmias. So it's some sort of broad spectrum. It's effective in different types of arrhythmias. As you can see, it can be deposited in the cornea, can be deposited in the thyroid, can be deposited in the pulmonary tissues. Okay, so it's producing these side effects, even in the skin with skin discoloration. Okay. And any anti-arrhythmic drug can result in another type of arrhythmia. Take it as قاعدة. Any anti-arrhythmic drug can result in a different type of arrhythmia. There is another derivative which is called dandrolone, also has a class 3 anti-arrhythmic action with less side effects. You also need to know, just to know the use, anti-arrhythmic use of each of these, like adenosine. This is good for AV nodal reentrant tachycardia. It's going to block AV conduction, so it's always good for supraventricular and nodal tachycardia. Digoxin for atrial fibrillation. Magnesium sulfate is the choice drug for Trousette de Pointes. What's Trousette de Pointes? Do you know about it? Polymorphic ventricular, Trousette de Pointes, yeah, again. With prolonged QT interval, okay, sometimes you get multimorphic ventricular arrhythmia and ventricular tachycardia due to the prolongation of the QT interval. So it's not the prolongation of the QT interval which is dangerous. It is the ventricular arrhythmia that happens due to it. And it will be ventricular arrhythmia, okay? In which case, it's going to be treated with magnesium sulfate. Ivabradine, of course, you know about it. So this is all what you need to know about arrhythmia. Huh? الإيه? Yes. Okay, so right. If I am going to look into the chapters you have, if I'm going to look into the chapters you have in this book, خلاص? Let's كده span the chapters. I was thinking yesterday, we have the autonomic nervous system. We have the autocoids. Then we have what? Ocular, skeletal muscle. Then we have cardiovascular system with everything in it. Then we have the blood and the anticoagulants. You know what would be the most important chapter? Anticoagulants. Anticoagulants and antiplatelets. By far. I was thinking yesterday, this is what I was thinking. And what is this? Are you going to prescribe beta blocker or amlodipine if you are not a physician? No. Are you going to prescribe a drug for arrhythmia? No. Are you going to treat angina? No. Are you going to treat migraine? يعني okay, ماشي, patient has migraine, تمام, so what? However, if you are a surgeon, you will use anticoagulants. If you are a physician, you will use anticoagulants. Anticoagulant use can kill people. And lack of anticoagulant use can kill people as well. And then I looked into the lectures, and I found out that we have 6 lectures for thromboembolic disease and anticoagulants, and said, okay, this is correct, this is right. So there is a good part of your exam about anticoagulants. ها الايه ده؟ ما فيهوش اسماء الانتيكواجولانتس؟ ما فيهوش anticoagulants، معلش. It will be in the next يعني sometimes we need to get on with things for the sake of your time. We didn't want to delay the book more. So don't worry. If you follow the ILOs and you make sure that you can target these ILOs from what's in your book, you are good. Okay? because not all the questions will be from the MCQ book anyway. Type. So this is, of course, a revision of the coagulation cascade, blah, blah, blah. So how do we, what's the most important thing? Classification. How do we classify anticoagulants? First of all, we don't want to forget that there will be anticoagulation in vivo and anticoagulation in vitro. Why is anticoagulation in vitro important? Because you have a blood sample that needs to go to the lab. So you need to put an anticoagulant on that blood sample. As a doctor, or more commonly, as a nurse, you need to know this. Okay? Now, in vivo, you need to anticoagulate a patient. There is one anticoagulant which is good for in vitro and in vivo use, which is the unfractionated heparin. That's why it can be also used where? In dialysis machines. What are the dialysis machines? Patients going to perform hemodialysis, they have renal failure. What do they do with these patients? They take their blood, the blood passes through a machine and becomes equilibrated with a dialysate. Dialysate will absorb by concentration gradient all the ammonia, the urea, the metabolites, and it's going to give, this is going to be equilibrated, and then the blood circulates back into the patient's body. You need here anticoagulation. Anticoagulation of the machine and the patient, and this is by heparin. So heparin is good for vitro and for vivo. Tamam? So this is just to give you the bigger picture. But what about in vivo? How do we classify the ones in vivo? We classify them by their route of administration. Route of administration here is very important. So you have parenteral anticoagulants and oral anticoagulants. Can you find anything here that can be used orally and parenterally at the same time? Can you find anything here that can be used orally and parenterally at the same time? No. So this is completely two groups, two different groups. The parenteral, we have direct thrombin inhibitors and direct thrombin inhibitors and direct thrombin inhibitors, heparin-like anticoagulants. What is this? Let me see. Indirect and direct, I'm so sorry. Indirect and direct. And the indirect inhibitors, because they act through something called the antithrombin 3. And of course, I didn't revise the coagulation cascade, but you are going to revise it. That with the coagulation cascade, you have things that go into the coagulation cascade, and you have mechanisms in our body that are going to inhibit this coagulation cascade to maintain the balance. That's why there is an antithrombin 3. So these indirect anticoagulants, the parenteral, they are going to potentiate the action of this antithrombin 3. That's why we call them indirect anticoagulants, and they are all parenteral. We have the unfractionated heparin, the low molecular weight heparin, and fondaparinux. Now, the direct thrombin inhibitors, they are newer. They are all used in specific indications, and you will find one indication or one sentence on each of them. Oral anticoagulants, we used to live in an era we had only warfarin as oral anticoagulant. It was the only one. Whenever you needed an anticoagulant, you had to take warfarin. You had no other choice. That was maybe until something like 20 years back or something like that. Maybe 15, 20, I'm not very sure. Maybe 20 years back. Yeah. 20 years back. You had only warfarin. That's why sometimes you find in the book written oral anticoagulant, while what is meant is actually warfarin. So be aware of this, because I have marked some of them, but maybe some of them are still hidden. Yani be aware of this. Sometimes it says oral anticoagulant, but actually it means warfarin, because there were days where warfarin was the only oral anticoagulant. Type. For the purpose of your exam, I don't know why I decided I'm not really going to ask about the unfractionated heparin this time. I had to take something out, okay? But you need to know very well the comparison between unfractionated and low molecular weight heparin and why low molecular weight heparin is has advantages. Okay, then let's continue. See, so these are the parenteral. You can see the heparin highlighted, but if you are going to revise the ILOs, you will see that I have not marked the unfractionated heparin in the ILOs. When you receive the ILOs, you will not find unfractionated heparin this time. However, what's wrong with unfractionated heparin? Unfractionated heparin can be given intravenously. This is an advantage because not all the parenteral can be given intravenous or subcutaneous. Yani they're just parenteral. Low unfractionated heparin can be given subcutaneous or intravenous. Low molecular weight heparin can be given just subcutaneous. Low molecular weight heparins can be given only subcutaneously. Only subcutaneously. So whenever you find a heparin infusion needed, it will be unfractionated heparin. So that's an advantage. But on the other side, heparin is short-acting. When I was an intern, when we were interns, there were no low molecular weight heparins. Each post-operative patient taking heparin, every 6 hours, we take a blood sample and we keep doing the clotting time for how many minutes? Clotting time normally is 7 minutes. Another rule, when you give an anticoagulant, you're not going with the physiology. You are anticoagulating the patient. You're putting the patient on the anticoagulated side. You are prolonging bleeding time and coagulation time. You are not putting the patient to normal. If you have a relative who's on anticoagulant, you look into prothrombin time and INR, it has to be outside the normal. It has to be times the normal. So we do the clotting time for 20 minutes. Every 6 hours. نبطشية كلها كده. نبطشية كلها clotting time heparin. دي مشكلة. فطلع لنا مين؟ طب وليه؟ Action is not predictable. Heparin is a very big molecule. It is labeled by units of activity. When it enters the body, it will undergo enzymatic degradation. So you cannot relate the amount of heparin as an amount to the amount of effect you will see in the patient's body. You always need to monitor. Okay? So came the low molecular weight heparins. They are smaller molecules, but they are still large. They cannot pass the placenta. They are still quite large. However, the molecules are almost equal in size, and they don't undergo all this degradation like heparin in the body, not in the same way. So you can predict the action. And when they are given only subcutaneously, you can give them once or twice daily. So they are predictable, they don't need monitoring, and so they are safer and more convenient to use. This is what you need to know about the low molecular weight heparins. Okay. So low molecular weight heparins, they are produced by chemical enzymatic depolymerization. The weight is around 5,000 daltons. So again, this is a large molecular weight, so they will not pass the placental barrier. You can give them to a pregnant female. They potentiate the effect of antithrombin 3. However, this is slightly different because antithrombin 3 is going to inhibit thrombin and factor 10. With low molecular weight heparins, they are more selective in inhibiting factor 10, more than thrombin. Okay, they can be again neutralized by protamine sulfate. However, this is not complete. So if there is bleeding due to low molecular weight heparins, you can still give protamine sulfate. However, the antagonism will not be complete. They are all given subcutaneously, but with less frequent dosing, once or twice daily, because they have longer T-half, and no need for laboratory monitoring because there is predictable pharmacokinetics and pharmacodynamics because they do not bind to plasma proteins, macrophages, platelets, less likely to cause thrombocytopenia. So these are all advantages of low molecular weight heparin. طيب do we ever need to monitor low molecular weight heparins? Ever? Yes, we do. If the patient is a normal patient, usually we don't need to monitor. However, if the patient has renal insufficiency, we don't know their half-life, we need to monitor. If the patient is pregnant or if the patient is obese, we don't know how they will be distributed. Sometimes you need to monitor. You don't monitor by activated partial thromboplastin time. You monitor by factor 10A activity because they are more specific to factor 10. Okay, so you monitor by something called factor 10 activity, okay, or the activity of factor 10. So factor 10, anti-factor 10A assay is designed to measure plasma low molecular weight heparin levels. Therapeutic range, you don't need to know the therapeutic range at all. They are as effective and safer than unfractionated heparin with less frequent hemorrhage and less frequent thrombocytopenia. تمام. طيب. What do I need to say here? Yeah. Yes, I remember. It says they can be given once or twice daily. There is another very important thing that I want you to know. What are anticoagulants used for? If you want now to describe the uses of anticoagulants, what are they? ما بيدوبش حاجة. It's not dissolving a clot. What dissolves the clot are the fibrinolytics. From the name, these are anticoagulants. They prevent coagulation, but they don't dissolve the thrombus. What dissolves the thrombus is a fibrinolytic. That's why when you give a fibrinolytic, you take it in the practical, it has to be within a window, within a time frame. So why do you use anticoagulants? You have basically two indications of anticoagulants, two indications, and then you can ramify from these two indications. What are the two indications? Treatment and prophylaxis. Either you are treating DVT or pulmonary embolism. Okay, you are not going to dissolve it. So why are you giving them? You don't want it to extend more. But you cannot call it prophylaxis because DVT has happened already. So now you need to anticoagulate this patient to limit the coagulation. And there is prophylaxis. You know this patient is high risk. So you want to give prophylaxis. You are not waiting for coagulation to happen. Right. Why is this important? I remembered it when I saw once or twice daily because classically speaking, the treatment dose is twice daily and the prophylaxis dose is once daily with the low molecular weight heparins. So when I saw the once or twice daily, I remembered that I need to tell you that there will be prophylactic and therapeutic indications for anticoagulants. تمام؟ طيب, Thrombopherinox, again, it's not very important for the purpose of this exam. And then there will be the direct thrombin inhibitors. They are again parenteral anticoagulants. Now these are important for the coming exam. Most of them can be given subcutaneously or IV. We have the Lipirudin, Bilaverdin, and Argatroban. And here I need to talk about something called heparin-induced thrombocytopenia. What is heparin-induced thrombocytopenia? Form of immune reaction to heparin. What happens is an activation of platelets with wide consumption of platelets in the body. When all the platelets are consumed, there will be thrombosis, and then there will be thrombocytopenia because the platelets are consumed. Is this dangerous? It's very dangerous. I told you yesterday that anything that messes up with neutrophils, with immunity is very dangerous. Anything that messes up with platelets is very dangerous. Hemorrhage is very dangerous. Anticoagulants are very dangerous. You can get headache as big as this, and the patient doesn't die then you get a drop of blood. A drop of blood in the CNS. And a patient dies or becomes paralyzed. That's why anticoagulants are very important and are very dangerous as well. So, heparin-induced thrombocytopenia. What is the main thing that you need to make sure of when you label a patient as heparin-induced thrombocytopenia? That you don't give any form of heparin anymore. No heparin anymore. Because you have something written that low molecular weight heparins cause less thrombocytopenia. They are less antigenic. They will cause less thrombocytopenia. They are safer. But once there is heparin-induced thrombocytopenia, you never use لا unfractionated heparin ولا low molecular weight heparin. Type. This patient can have 2 levels of needs. This patient will sometimes need to be anticoagulated because he needs anticoagulation. And sometimes he needs anticoagulation because he's in the thrombotic phase of the heparin-induced thrombocytopenia. So what to do? You have to know your options for anticoagulation of this patient. Whether this patient is in the thrombotic stage and you want to treat him now, treat the thrombocytopenia that's coming, this immune activation of platelets, or this patient needs anticoagulation anyway. So you need to provide an anticoagulant. So we have Lipirodin is one of the drugs that can be used. However, argatroban has FDA approval for treatment of heparin-induced thrombocytopenia with or without thrombosis. So whether the patient is in the thrombotic stage or whether the patient still needs anticoagulation and is not in the thrombotic stage, you can use argatroban. And why argatroban? Because it has FDA approval for this. Okay? Huh? It depends on the case. يعني, let's say the bleeding is now better and now, or is, let's say the bleeding now is better and the patient now needs anticoagulation. Let's say the patient is going into coronary angioplasty and this patient needs anticoagulation. Okay? تمام. So, warfarin. طيب. Warfarin. Let me see, and I want to remember what ILOs we have for warfarin. Do we have other ILOs here? Let me see. Yes. Because I want to be very much to the point now. You will receive these ILOs from Dr. Hanan, okay? Ignore the blue ones, okay? Please, just concentrate at the yellow ones. Okay? ها؟ ايه اللي بالاحمر؟ مفيش احمر. مفيش. Yeah. طب warfarin. Are we still using warfarin? How does warfarin act? Warfarin is a competitive inhibitor or competes with vitamin K. Now, vitamin K, it donates hydrogen, okay, for the activation of clotting factors 2, 7, 9, and 10, and protein S and protein C. What are protein S and protein C? They are endogenous anticoagulants. Why do we need endogenous anticoagulants? As I told you, just like the antithrombin, if you have a coagulation cascade, you have something to balance it out. So this balances out the coagulation cascade. Type. Why is warfarin an anticoagulant? Because when you give warfarin, you put the patient on the anticoagulated side. The decrease in formation of factor 2, 7, 9, and 10 overbalances the decreased formation of protein S and protein C. And the patient becomes anticoagulated because he's not metabolic or not making these 4 factors. Warfarin has so many disadvantages. First of all, it is going to have delayed onset. Why? You have coagulation factors. Second, it is going to have long duration of action. Why? Highly bound. It has a very long T-half. Then it is metabolized by the cytochrome P450 enzymes, by two different cytochrome P450 enzymes, which is a site for drug-drug interaction. So if I give any drug, it might increase warfarin level, decrease warfarin level, cause anticoagulation and bleeding, or failure of anticoagulation and thrombosis. What else? Vitamin K. This is the natural antagonist of warfarin. Where is vitamin K found? It is found in green leafy vegetables of all sorts, and it's found in meat and eggs. Anything different the patient is consuming or eating is going to give vitamin K. If the patient is eating a style of meal today and tomorrow he's changing the style of food, you're going to get increase or decrease in warfarin action, not level. This is على فكرة dynamic drug interaction, because it's increasing and decreasing vitamin K, which is a competitive antagonist of warfarin. So this is a dynamic, not a kinetic interaction. Drug-food interaction of warfarin is a dynamic interaction. تمام؟ تمام. طيب, so this is very dangerous now. This is a very bad drug. It has delayed onset, long duration. It is very dangerous, and it has drug-drug interactions and drug-food interactions. Are we still using it? We are, because it is very effective. You have a table in your book, okay? You know the table. I'm going to bring it over. This table has all the anticoagulants and the indications for each. You memorize this table. This table is important. The comparison between indications of different anticoagulants. You still have warfarin. You still have warfarin with special indications. So what do? We have to monitor warfarin. So how do we monitor warfarin? What is INR? Warfarin will increase something called prothrombin time, meaning that we take the patient plasma. Okay, we take patient blood sample. Take the patient plasma. We take a patient blood sample, and we stimulate coagulation. And we count the time when prothrombin forms. Okay, naturally, it is going to take, I think, maybe 20 seconds, something like that, and there will be prothrombin. So this is called the prothrombin time. Do we need it to be normal? La, we are anticoagulating the patient. So we need it to be 2.5, 2, 3 times normal according to the indication or level of anticoagulation that you want. It's different sometimes. There are targets. Type. What if the reagent itself is not unified? There is something wrong with the reagent. Differences in different reagents will give us different prothrombin times. We cannot depend on it. So what do? We got patient plasma and we get control plasma. We are sure that this is control. We are sure that this prothrombin time, let's say, is 15 seconds. We are sure it should be there. Or this is normal. This is a normal sample. And we calculate the prothrombin time in the patient sample and in the control sample. And then what do? We divide the patient sample prothrombin time by the control sample prothrombin time. So what do we get? A ratio. We call it international normalized ratio. And the point here is to avoid variability in the kits, variability in the reagents. So this is the famous INR, which needs to be 2 to 3 times the normal to monitor warfarin. Okay, so this is the whole story of monitoring warfarin. So if you have so many interacting factors in the patient has to do regular INR monitoring. So initiation type. What? Because the warfarin initiates its action late. So what do? If the patient needs anticoagulation now, we give heparin with the warfarin. Now we heparin, and sometimes we can give direct oral anticoagulant, or we just, if we can, we put the warfarin aside and we just give direct oral anticoagulant. So the direct oral anticoagulant, they don't need heparin in the beginning. However, warfarin needs heparin in the beginning, okay, until we see a change in the INR, until the target that they want to reach. خلاص INR reaches target كده تمام. So describe the initiation, explain how food drug interactions influence the effect of warfarin, explain the advantages of direct oral anticoagulants over warfarin, and mention the antidote of each anticoagulant and classify hemostatics. So now we know our homework. On the Zoom, is the sound okay? I want to know, on the Zoom, is the sound okay? I'm not really sure. I don't get an answer. So let's see just what we get. So this is the story about the prothrombin time and the INR. And then these are the side effects of warfarin. They are important. Drug-food interactions. These are the factors that influence warfarin action. Some of them are kinetic, some are dynamic, some increase its action, some decrease its action. And then there are the direct oral anticoagulants. Okay. So let me just read the advantages. Predictable kinetics and bioavailability. This is in relation to warfarin, which allow for fixed dosing and predictable anticoagulant response, unlike warfarin. Routine anticoagulation monitoring, is it necessary? Not necessary, unlike warfarin. Less frequent follow-up, faster onset and offset of action, allowing immediate anticoagulation and avoiding the need for overlap with anticoagulant, fewer drug and food interactions. So these are the direct oral anticoagulants, the newer ones. They are very important. You need to know there are two classes. You have the direct thrombin inhibitors like dabigatran, okay? Then you need to know the antidote for each. Because the antidote for an anticoagulant is important because it can save a patient's life. So the antidotes for anticoagulation are important because they can save a patient's life. Here, for dabigatran, we have a monoclonal antibody. It's called idarosizumab. Again, idarosizumab. It's a monoclonal antibody. For the oral direct factor 10A inhibitors, we have rivaroxaban and apixaban, and both are important. These are the two names that I need you to know about. And the antidote is called adenexanate alpha. This is again an antidote. You can see here that the antidote for rivaroxaban was discovered in or approved in 2018. That for idarosizumab was approved in 2015. 3 years left, even though rivaroxaban received approval, I think, before dabigatran. So companies are running to provide an antidote for the anticoagulant because this is a big plus point. If you anticoagulant with an antidote, this is very good. If you have bleeding that you cannot control, this is a mess. Now, for the anything about anticoagulants, فضل. امشي مع الايلوز بس. الاصفر. The yellow highlight. طيب, let me see. Have I written this? Let me see. I want to remember. Please refer to the ILOs below for the end of module exam, concentrate on the ILOs highlighted in yellow. Okay? Will be sent to you. خلاص صدق ال ILOs. تمام؟ Which is not cancelled. You can see it in the exam, next exam. But I want to make sure that you study it somehow, sometime. And I know that this is going to be even better because I am dead sure that you are going to know everything this way. If you concentrate on something and you concentrate on the other and there will be some overlap, I am sure by the end of the year you have studied everything, inshallah. طيب نرجع تاني. What do we have here? We have the coagulants. What I need you to know the classification. Of course, the anticoagulants are much more important than the coagulants, but the coagulants are still important because the patient will be bleeding. Okay, so you need to control the bleeding. There are local hemostatics, mostly non-pharmacological. And then there are something called the active hemostatics. I don't need any names. خالص. Then there will be systemic hemostatics. Now these systemic hemostatics, some of them are like vitamin C, vitamin K, and some you can classify them. Yani for example, vitamin K, this is a vitamin, and this is in cases of hypoprothrombemia or with warfarin overdose. Vitamin C, this is specific to scurvy, okay? Protamine sulfate, this is the antidote for heparin. Does it work with low molecular weight heparins? Yes, but partially, not totally, but it works. Yani it will not be, okay, type. You have what else? You have desmopressin. Desmopressin is a synthetic, is a derivative of antidiuretic hormone, which is a vasospastic drug or a vasospastic hormone, and it's going to release factor 8 and von Willebrand factor from the vascular endothelium, and it can be given IV or subcutaneously. So you can see it مثلا in bleeding esophageal varices. So here you see 4 that are used in specific situations. Desmopressin, mostly in something like esophageal varices. Okay, it's very, very potent vasoconstrictor and coagulant. Okay, see vitamin C in scurvy. You have vitamin K in hypoprothrombemia. And what else did we say? And protamine sulfate. The other ones are blood products. Other ones are blood products. You have human fibrinogen. Okay, you have anti-hemophilic globulin. This is factor 8. It's given IV in hemophilia. You have antifibrinolytics, tranexamic acid. Okay, this is again, if you have fibrinolytics, this is again special, not a blood product. You have fresh blood transfusion. If you don't have any of these concentrates, they are expensive. Yani if you're looking for anti-hemophilic globulin or human fibrinogen, or you're looking for cryoprecipitate, these are all expensive things. If you don't have them, then you use fresh frozen plasma. If you don't have it, then you give fresh blood transfusion. Okay, so these are all, you can classify them into blood products and things used in special situations, or coagulants used in special situations. Sclerosing agents, why do you need to know about sclerosing agents? Because you will see them in bleeding esophageal varices. This is when you inject something inside the vein to obliterate the vein. I don't want you to memorize the name. I just want you to know what does it mean, sclerosing agent. You are living in Egypt. There are still people with hepatitis, cirrhosis, esophageal varices. For that, by endoscopy, you sclerose the veins. So just the term sclerosing agent. طيب ايه تاني كمان؟ Vitamin K. For vitamin K, you just need to know the names of the preparations. Okay, that is available orally and parenterally, and when it's used. Okay, when there is inadequate intake, when there is warfarin overdose, when you're taking broad spectrum antibiotics, so no vitamin K production from intestinal bacteria. So these are just general. Now, antiplatelets. Very important. Let's go back to the ILOs. What do I need you to know about antiplatelets? here. Yeah. Mechanism of action of different classes of antiplatelets. Do I have a slide here? I think I have a nice slide. I think I have a nice slide. These are the sclerosing agents injected inside the vein, as you can see, for varicose veins, and the same for esophageal varices. This is the slide I like so much. This is the platelet, okay? Now, for platelet aggregation to happen, okay, this is the ultimate receptor that's going to be activated for platelet aggregation, which is called the glycoprotein 2B3A receptor. This is the ultimate, okay? Anything arrow moving to this side is going to increase platelet aggregation. The arrow moving to the other side is going to decrease platelet aggregation. So what will increase platelet aggregation? Increase in the calcium inside the platelets, and this can be achieved with different things, but we have one of them is thrombin. So thrombin is going to increase platelet aggregation. Concentrate here, this is important. Then you have the thromboxane A2. So you have the thrombin, okay? I'm talking about mediators that can be targeted. Mediators that will be targeted. Type. On the other side, platelet aggregation is going to decrease with anything that increases cyclic AMP inside the platelet, either by stimulating adenyl cyclase inside the platelet and producing cyclic AMP, or stopping the degradation of cyclic AMP. So how can we decrease platelet aggregation now? How can we decrease platelet aggregation? We have things that will inhibit thromboxane A2, which is like aspirin. This receptor for thrombin is a new receptor. There are new drugs that are going to act on this receptor, okay, and block it and inhibit platelet aggregation. Now, we can inhibit phosphodiesterase inside the platelet by dipyridamole. Okay, however, it's not very commonly used now. It's not a very important drug. This is very important. This receptor is called the ADP receptor, and it's blocked by clopidogrel, anticlopidine, and prasugrel, blocking this ADP receptor, and it's going to inhibit the formation of cyclic AMP inside the platelet, and it's going to decrease platelet aggregation. Ultimately, you can block the ultimate receptor, which is the 2B3A receptor. This is blocked by some monoclonal antibodies or by drugs that are expensive and are powerful, like abciximab, tirofiban, eptifibatide. So these are the antiplatelet drugs, atoxabar and vorapaxar, okay? Atopaxar and vorapaxar, these are the new drugs that I was talking about. And these are the blockers of 2B3A receptors, okay? And these are the inhibitors of thromboxane. And this is what we call the ADP receptor antagonist. Another name is the P2Y12 receptor. So these are the main drugs inhibiting platelet aggregation. تمام؟ طيب. So you need to know the mechanism of action. Why is aspirin long acting, and why is it most efficient in inhibiting platelet aggregation? Because it will produce irreversible inhibition of the cyclooxygenase enzyme. Why is this important? Because there is prostacyclin on the other side, but the prostacyclin is produced from the endothelium, and the endothelium can recover its prostacyclin. So endothelium will keep recovering its prostacyclin to inhibit platelet aggregation. However, the platelets will never recover their thromboxane A2. Why? Because they were released from the bone marrow with a fixed amount of enzyme. They cannot regenerate another enzyme. نسميهم صفائح دموية. They are not cells. They don't have nuclei. They don't synthesize. They just come from the bone marrow with whatever they have. So you have to wait for 7 to 10 days for other platelets to form. That's why aspirin is effective and it has a long duration of action, can be totally reversed after 7 to 10 days. So this is important, okay? So this is talking about aspirin. There is something here. When we say, by the way, if you open Katzung's textbook of pharmacology, you will not find the big chapter on aspirin you will take next year. Because aspirin in our country is one drug, and in the world it's another drug. In Katzung and all the textbooks, the only use for aspirin now is what we call the low-dose aspirin for platelet inhibition of platelet aggregation in patients with angina, with cerebral thrombosis, primary, secondary prevention. This is aspirin. This is what we call low-dose aspirin. But what's a high-dose aspirin? It's the one we use here in Egypt, not rheumatoid, for rheumatic fever. But how big is the dose? You measure it in grams. You give aspirin to children with rheumatic fever in grams. مش بقى 50 ملي 70 ملي جرام و100 ملي جرام وحتى 300 ملي جرام. And I want to highlight this because some people think that the small dose is 100 and the large dose is 300. لا. The small dose is 100, the large dose is in grams. 10 grams, 12 grams for rheumatic fever. This is the large dose aspirin. But in coronary artery disease, in the guidelines, you will find the 100, the 75, the 300 for antiplatelet action. That's why what's written here is very important. Recommended ranging from 50 to 325 milligrams. And please consider this the only dose that I want you to know. Okay? تمام. Therapeutic uses, prophylactic treatment of cerebral ischemia, recurrent myocardial infarction, decrease mortality in the setting of primary and secondary prevention of MI. I need to do some explanation here. What do you notice here? What is this thrombosis? Where is it? Arteries or veins? Always arterial. Why? Because atherosclerosis is a disease of arteries. And it is dependent on platelet aggregation for thrombosis. However, veins depend on stagnation and hypercoagulability. So you use anticoagulants for which thrombosis? Venous, because you have in your book with heparin and warfarin indication called cerebral thrombosis. This is not cerebral artery. This is the cerebral venous plexuses. So, anticoagulants are for venous thrombosis. And antiplatelets are for arterial thrombosis. This is the golden rule, and there are a few exceptions. Yani in angina myocardial infarction, you use heparin. Why? It has an antiplatelet action, okay, and you want to do some anticoagulation. هتقول ايه؟ cerebral vein. انت مش الفين، اقصد venous plexuses. You know about the venous plexuses in the brain? They can get thrombosis. So this is where you use an anticoagulant. But if you mean thrombosis in cerebral arteries, it has to be antiplatelet agent. The question is, استعمل one antiplatelet agent ولا more than one antiplatelet agent? This becomes a question. Do I need two? Sometimes I need two. Okay? So these are the therapeutic uses, mostly arterial. Then what's important about clopidogrel? Clopidogrel is a prodrug. And it is metabolized, so it acts on, stimulates the expression of the receptors, decreases ADP, decreases activation of these receptors. Clopidogrel inhibits reversible binding of ADP to it inhibits the binding of ADP to P2Y12 receptors. These are the ADP receptors that I showed you. And so these activated receptors will stimulate the expression of glycoprotein 2B3A receptors. Now remember the diagram. Remember الأسهم. Remember ال ADP receptor وكان بيعمل cyclic AMP والسهم رايح ناحية مين؟ ناحية ال 2B3A receptor. ناحية ال platelet aggregation. كل ده هيبقى inhibited. كان في ticagrelor دوت is another member reversibly inhibiting ADP to its receptor. واحد reversible واحد irreversible. انا مهتمه قوي بالدراج انتراكشن بتاعه الكلوبيدوجريل. هقول لكم ليه. الاسماء هنا مهمه. التيكاجريلر والكلوبيدوجريل الاثنين مهمين والبرازوجريل. طيب ايه بقى فكره الدراج انتراكشن دي؟ الكلوبيدوجريل is a prodrug. It is activated by the cytochrome. Usually when we have an enzyme inhibitor, what does it do to the drug? يزيد. When we have an enzyme inducer, what does it do to the drug? طيب هنا العكس. And you will see this with any prodrug dependent on the cytochrome. يبقى a prodrug must be activated by cytochrome P450. Major interaction with drugs that inactivate the microsomal enzymes. PPIs, proton pump inhibitors, drugs used for peptic ulcer. Omeprazole will inhibit the cytochrome. لو انت قلت لي enzyme inhibitor, I will tell you what? It's going to increase the level of the drug. But this is a prodrug that needs activation. So proton pump inhibitors like omeprazole, they are enzyme inhibitors. They will inhibit the change of the prodrug to the active drug. So they will prevent activation. Is this dangerous? Yes, the patient will get thrombosis. Takes clopidogrel, takes proton pump inhibitor omeprazole, he gets thrombosis because he doesn't have an antiplatelet and he needs an antiplatelet. These are the approvals. Unstable angina. Against unstable angina, you take it in the practical. And now this is the glycoprotein 2B3A, abciximab, iptifibatide, antirofibin, blocking this receptor, which is the ultimate receptor for platelet aggregation. They are very powerful. They use by IV infusion. And they are licensed for high-risk patients performing coronary angioplasty. Now, what's coronary angioplasty? ادخل retrograde وتوصل للcoronary and you stent it and you dilate it. This is coronary angioplasty. Ultimate treatment for coronary block or coronary ischemia. Dipyridamole, it's not an important drug anymore. It is weak. It's not very important. Thrombin inhibitors or thrombin receptor inhibitors, Vorapaxar and Atopaxar. These act, it's just to know that these drugs and act on these receptors, that there are drugs existent that do this. Type, we have the fibrinolytic drugs. Again, they are important. And why are they important? Yesterday, I was going through the textbook of internal medicine, the one you are going to study. And they don't really give much about the drugs. I felt a bit of a responsibility because what we teach you now, you're going to carry it to your practice. Okay, so I was reading about the fibrinolytic drugs and the fibrinolysis. Now, how are fibrinolytic drugs different from anticoagulants? They actually dissolve the recent thrombi. They actually dissolve. That's why you need to use them within a window so they can act. But after a while, these thrombi, they become, let's say, old, and you cannot lyse them anymore. So each part of the body, you'll take in that in the practical, has a certain window. Okay? So indicated in multiple pulmonary emboli, pulmonary embolism, even in DVT, acute myocardial infarction, peripheral vascular disease. You have some of them. You have the streptokinase. You have the tissue plasminogen activators. You need to know about these. Streptokinase is old, is cheap. It is synthesized by streptococci. It combines with a pro-activator plasminogen, okay, to form an enzymatically active complex that's going to do fibrinolytic activity. However, very bad about it, not just the bleeding, all fibrinolytics will lead to bleeding, allergy. Okay, so urokinase is actually synthesized by the kidney, not very much used now. Now, the important drugs now are the anistriptase. Actually, this is also has streptokinase inside it. Even more important is alteplase and reteplase. Why? Because these are obtained by recombinant DNA technology. This means that they are going to be less antigenic. Okay, they are selective to the clot. And they have short half-lives. They are given by IV infusion. Okay, so you need to know about them because they are less antigenic and they are the ones mostly used now. Now, just as you have the fibrinolytic system, you have antifibrinolytics. What are antifibrinolytics going to do? Treat what? Antifibrinolytics, they are going to treat what? Okay, they are going to treat thrombosis or bleeding? They are going to treat bleeding. Okay, actually, you give them in bleeding where you have a suspicion with high activity of fibrinolytic system. Sometimes there's something called disseminated intravascular coagulation. Fibrinolytic system is active in all the body, so you can try to use these. Patients who are performing some operations like prostatectomy or bleeding after fibrinolytic therapy, if you know that the bleeding is due to fibrinolytic therapy, post-prostatectomy, you have many mediators, okay, that have fibrinolytics. So you can use antifibrinolytic agents. These drugs, aminocaproic acid and tranexamic acid, they are important. They are used commonly, so you need to know about. They antagonize the plasminogen activators, and as I told you, they are used whether there is an overdose of fibrinolytic therapy or you have bleeding in situations where you expect there is high activity, the high fibrinolytic activity. Okay, here, what I need you to know is this table. I couldn't highlight the table. I couldn't highlight it, but I'm telling you now, this table is very important. Okay? Fine. We are left with what? I want you to look into the questions. Oh, okay, we have anemia and we have the lipids. Anemia is going to be simple. Let's shift to the ILOs of the anemia to make things very specific. We have two types of anemia. You have iron deficiency anemia and you have pernicious anemia. With iron deficiency anemia, is it important? It's very important because it is very common. Many people will have complaints. They don't know where it's coming from. They have fatigue. They cannot perform work. There is lack of concentration. There is headache. You simply send them to make a blood picture and you discover they are anemic. Iron deficiency anemia may be because they are not taking good amount of iron in food, so maybe nutritional. Sometimes there is chronic bleeding and you don't know about it from piles, from GIT bleeding, taking non-steroidal كتير. So they have ulceration and they don't know about it. So they keep trickling blood, they don't see it, and they get them anemic. So anemia has to be treated because it will change the patient's life. Patient with heart failure, if he gets anemia, he's decompensated, becomes decompensated. So you treat anemia oral or parenteral? Oral whenever possible. So قاعدة نمرة 1, oral is as good as parenteral unless the patient can take oral. They are severely vomiting, so they cannot take oral. Or there is some other problem, big problem that prevents oral intake or making this not suitable. Otherwise, always oral. Type. What's the precaution about oral and what's the precaution about parenteral? Precaution about oral is that you will find, first of all, you need to take it with an acid, better, okay, because it will increase the absorption. Ferrous is better absorbed than ferric. You all know about this. But many iron salts exist. to the milligrams that you see, they reflect the salt. You need always to translate this to elemental iron. How much iron is there? I'm not telling you to calculate. I'm not giving examples. I'm not giving problems. Just for you to have this insight that iron gluconate will not the same as sulfate, will not the same as whatever salt. They are different. You change the dose when you change the salt. This is one thing. What about the parenteral? The problem with the parenteral is the allergy. It can have very serious reactions. That's why sometimes you need to give a test dose to the patient to see how the patient is doing. And sometimes you need to give fluids and antihistaminics and so forth. So anemia, what do we need to know? Explain the importance. This is iron deficiency anemia. Explain the cautions with parenteral iron administration. You're going to look at them in your text. Compare parenteral to oral iron advantages. You're going to read whether there is a difference between them. And explain the importance of calculating elemental iron in oral preparations. We're not telling you to calculate, but you need to know that calculation is important. Now, other topic is the pernicious anemia, which is due to, if anemia is megaloblastic due to folic acid deficiency, you give folic acid. And some people, they just need folic acid. Like, for example, if a mother is pregnant and is treated with anti-epileptic, you need to give her folic acid. You give her folic acid in first trimester anyway. This is pregnancy category A. She will not get any harm from folic acid. So pregnancy in the first trimester, all through pregnancy, they take folic acid. However, if you have vitamin B12 deficiency, you need vitamin B12 for neurological health and for blood health. You need it for the blood cells and you need it for the neurons. So the glitch here, or the problem here, if you mistake this megaloblastic anemia for folic acid deficiency and you just give folic acid, so what will happen? The blood is going to improve. Type. If you have this much vitamin B12, it's going to consume the vitamin B12. And the neurological symptoms will get better or worse? They're going to get worse. So you need to know whether you're dealing with just folic acid deficiency or this pernicious anemia, vitamin B12 deficiency, in which case you need to give both folic acid and vitamin B12, knowing that if you give only folic acid, you are going to worsen neurological manifestations. So this is what you need to know about anemia. We are left only with the anti-hyperlipidemic, very important. You need to classify them according to the mechanism of action. HMG-CoA reductase inhibitors are very important. You know them by the statin name, so you don't even need to memorize the statin name. HMG-CoA reductase is the rate-limiting enzyme in cholesterol synthesis. They are very effective in mainly reducing hypercholesterolemia with triglycerides as well. So you need to compare which classes will have effect mainly on cholesterol or mainly on triglycerides or both. Some things like the fibrates, they will reduce mainly the triglycerides. So you need to compare these options. Type. You use the statins with a target. يعني ايه? This is for you, not for the exam. You have a relative comes to you taking statin. This is my cholesterol. You look at the cholesterol and you find it normal. LDL by the lab is normal. Is this sure okay? No. According to the risk. Some people are very risky for coronary artery disease that they need to decrease cholesterol even below the normal. So you have guidelines and you have normal ranges. Sometimes you decrease cholesterol to 70 milligram per DL because this is a very risky patient. Type. Statins are very beautiful drugs. What are the problems with statins? Two things. Hepatic enzyme elevation. Again, a relative comes to you taking statins. These are my liver enzymes. Normal is 26. You find it 40. Is this serious? No, you treat liver enzymes by multiples. You get alarmed if liver enzymes are twice the normal or if the patient is symptomatic. But these are the liver enzymes. What about the muscle? What happens in the muscle? Myopathy, elevation in creatine kinase coming from the muscle. Myoglobin goes where? Disintegrates, leaves the muscle. Where's the problem here? Kidney. Whenever you say rhabdomyolysis, you look at the kidney is going to be damaged because this myoglobin is going to go into the urine, it's going to block the kidney, and the kidney will enter into acute renal failure. Besides, this rhabdomyolysis sometimes can be very painful. Some people cannot tolerate the statins. So, number one anti-hypercholesterolemic drugs are statins, HMG co-reductase inhibitors. This is the rate-limiting enzyme. They are very effective. You have a target of treatment. You have some pleiotropic effects. By the way, I'm not interested for you to memorize them. ده كل ده ايه؟ ده ريسيرش. يقول لك اصله بيعمل ما اعرفش ايه في البون، اصله بيعمل ما اعرفش ايه. مش مهم. هو كوليسترول. بقالنا سنين في الادويه دي. They are mainly hypercholesterolemic. طيب. اتفقنا؟ دي المشكلتين دول can make a patient not tolerating the dose that he needs. يعني he can take the statin but he cannot take big enough dose to reach the target اللي انا عاملاه له. So he takes something else. مثلا ezetimibe. What's ezetimibe going to do? Ezetimibe is going to decrease the absorption of cholesterol. He takes bile acid binding resin. Same thing. Okay. Type. What else? Breaking the interior hepatic circulation of cholesterol and okay, making the liver take up more cholesterol from the blood. Type. Patient can take also what? Niacin. Patient can take also what? Sometimes this patient is severely hyper and cholesterolic hypertriglyceridemic. He can take fibrates and statin as well. So what I want to highlight here, the importance of combinations of anti-hypercholesterolemic and anti-hyperlipidemic drugs. This table is an important table. What's so important about this table? When you combine, you usually want to add the effect, good effect, without increasing the side effect. Some patients are severely hypercholesteremic and hypertriglyceridemic. That you want to use what? SHMG co-reductase inhibitors, statins with fibrates. You have to use both. Okay? What's the problem here? Fibrates, just like the statins, they are going to increase liver enzymes and they are going to cause rhabdomyolysis. So here the risk of rhabdomyolysis is so great. I want to tell you something, that this is variable. Sometimes patient takes only statin and he gets severe rhabdomyolysis. Sometimes patient can tolerate 2 drugs. However, if you are talking risk, if you are talking probability, the highest probability of rhabdomyolysis will come from combining statins and fibrates. You need to know the mechanism of action of each class. You need to know the main side effects of each class. The new ones I have highlighted only. I'll show you the highlights now. Yeah. Again, follow the ILOs. ILOs are even stricter than the highlights. Follow the ILOs. This is the mechanism of action. These are the dynamics. As you can see, I have not highlighted. I've highlighted only improved endothelial function. Left out the rest. Research ده كل شويه تلاقي بيبر بيقول لك بيعملوا ما اعرفش ايه. انا نفسي عملت عليهم 2 بيبرز وانا بترقى. تمام؟ absorbed orally. Okay. تمام. taken mostly at night علشان في circadian rhythm في الكوليسترول production. Adverse effects as we told you. interactions. Okay. contraindicated تماما في البريجنسي تماما. niacin. Okay. mechanism of action. Kinetics, adverse effects again because it's characteristic. These are the fibrates. Okay. Okay, what else? Ezetimibe. Oh, okay. The recent ones, I need you to know bempedoic acid, okay, which is an ATP citrate lyase inhibitor that inhibits cholesterol biosynthesis. And so this is going to, anything that inhibits cholesterol biosynthesis is going to increase the expression of LDL receptors, is going to increase the receptors, and then the liver is going to take more cholesterol from the blood instead of giving cholesterol to the blood, okay? Thereby increasing the clearance of LDL. Again, the PCSK9 inhibitors, don't memorize the name, just know that something exists called PCSK9 inhibitors, because these drugs are in the market. And we were making the exam, cardiology exam. كنا عاملين cardiology exam. وكنا كاتبين كيس فيها هايبر لايبيديميا وكوليستروليميا. All the candidates of the cardiology, they wrote this drug. I knew this way that this drug is there in the market and it's being used, and the company is very active in promoting this drug, because all the cardiologists, they know about it. This is a very expensive drug. It's a monoclonal antibody, okay? Okay, which plays a role. I don't want the details. It's just that it's a monoclonal antibody that binds to this receptor, and this receptor, this is going to indirectly increase the uptake of LDL by the liver. I'm not interested in the details. Just to know that there is a monoclonal antibody, it is recent, and it's an inhibitor of something called PCSK9, okay? Just to know that it exists. These new drugs, I don't want any details about them. Then you have the anti-hyperlipidemic combinations, okay? If it's not normalized by a single drug, if you need to decrease both LDL and very low density lipoprotein, cholesterol and triglycerides, or if there is severe hypercholesteremia and triglyceridemia, and or you want to take lower doses. As I told you, sometimes the patient cannot tolerate the dose of statin that you want to give them, so you try to complete by using another drug. How this table works is, these are the HMG coagulants inhibitors and anything that can be combined with them. So you can combine HMG coagulants inhibitors with bile acid binding resins, with niacin, with ezetimibe, with fenofibrate, but the liver and muscle toxicities are common, of course. And you can combine them both with resins, ezetimibe, and niacin, so you can combine even more than 2 drugs. Bile acid binding resins can also be combined with fibric acid derivatives or with niacin, and that's it. Any questions? تمام? Okay, do well on the exam. You're gonna do well, inshallah. Okay, just follow the ILOs. Inshallah, you'll be very good. Okay? Best of luck. Thank you.